انا الحقيقه التوك بتاعي المفروض ان هو عن التروكانتريك فراكشر او توتال هيد التروكانتريك فراكشر زي ما الدكتور محمد اداني تاسك دوت، والتوك هيبقى شويه هنتكلم على التوتال هيد when it is needed in trochanteric fractures، ونتكلم على indications. واحنا عندنا two big categories يعني for the indication of total hip arthroplasty in trochanteric fracture، بالتاكيد being used as a salvage for failed fixation او for the complicated cases of trochanteric fracture. كمان احنا عندنا الانديكيشن بتاع total hip arthroplasty as a treatment for acute fracture. نتكلم شويه خلال الدقائق اللي جايه عن الديسيجن ميكنج. And then we may be able to cover some of the technical aspects. Obviously, not all technical aspects, but some of them can be covered during the talk. We'll talk about difficult and complication possibilities of the outcome on the long term to discuss. Trochanteric fracture elusive type of fracture to be treated. It affects elderly population. They are usually osteoporotic. There are many complications and fractures. دي بعض examples من different بعض examples من different devices and the methods of fixation being used. And you can see failure happening perhaps as a result of the suboptimal treatment options of internal fixation in other results of the comminution of the fracture itself. But there are many causes for the failure, and these are just some examples. There may be many more examples of the failure of fixation in these patients. The indication for total head to salvage failed fixation may arise as a result of the osteonecrosis of the femoral head with collapse, failure of some cases, infection that is extending to the head joint. That is when you can think of performing a hip arthroplasty to salvage the situation. How to evaluate these patients is very important to keep in mind. And it is, as being said by Professor Tariq Al-Khadrawi earlier during his talk, it is a holistic approach. You have to evaluate the patient as a whole. So it is an overall patient situation. You have, in all cases, whenever you have decided to perform an arthroplasty following internal fixation, when there is metal work, you have to exclude the possibility of infection. And the least should be done is ESR and CRP for all causes. Whether this is enough to exclude infection, I don't think so, because even when you get some patients with mild elevation of the ESR or CRP, ESR and CRP, and intraoperatively you discover that there is purulence around the mid. It's not possible in all cases to discover the infection preoperatively. CT in some cases you will need to perform a CT scan for assessment of the hip joint and the measure what is going on around the greater trochanter and the gluteus muscle attachment, because we know very well that the abductor mechanism is very important only for the function of the hip joint and for the ability of the patient to mobilize around, but also for the stability of the hip joint. Finally, you have to assess the bone stock, both on the acetabular as well as on the femoral side, to make your decision about the type of implant you are going to use and the length of your stem as well as what is going to be applied on the acetabular side. And before we proceed, I think infection is a very important factor and determinant factor. يصح ان احنا نبص على الانفكشن And according to presence or absence of infection, we can decide. For example, infection, if it is present, already that it is going to be a staged arthroplasty. It cannot be performed as a single stage arthroplasty can be performed. So it is very important at the beginning, or if you discover that intraoperatively, if it isn't, I think we should proceed for a single stage in presence of metalwork. If no terms of the investigation to preoperatively and what you have seen, the stage arthroplasty can be performed.
دكتور ايمن بيه، هو الصوت سعادتك بيقطع شويه.
طيب سامعني كده؟
ممكن سعادتك لو نقفل الفيديو هيبقى الصوت احسن بكتير يا فندم.
طيب اسمح لي ان انا ستوب شيرنج بعدين شير.
اوكي يا فندم.
Clear now?
تمام يا فندم. تمام.
Okay. What I will say is infection is very determinal in terms of the decision making. And if you see that this patient is infected, whether clear infection minus, for example, this is clear, but in a sealed wound, when there are investigation that is raising the suspicion of infection, you have to be prepared for arthroplasty instead of a single stage arthroplasty. If you discover that the patient is infection, whether preoperatively or intraoperatively, staged arthroplasty should be the line of management. But if there is no infection by both investigation and preoperatively, I think a single stage arthroplasty should be performed. And I'm sure that there are some centers around the world that consider the patients who are coming with failed internal fixation. They decide to perform this as a staged arthroplasty, even of lab results that may raise a suspicion of infection. They consider every patient for a staged treatment. They remove the metalwork first and then bring the patient back in 6 weeks or so for the procedure of arthroplasty performance. But I don't think we should perform this all patients. If you have someone whom you know there is no infection, with both in the lab results and intraoperatively with absence of purulence around the implant, I think you can proceed for single arthroplasty straight away. Now, difficult can be when you failed internal fixation. First, you have to be aware. You have to be aware that there is disturbed anatomy of the proximal femur. There is callus formation around the old fracture side. The medullary canal, if not obliterated by the callus, it's usually obliterated by the fibrous tissues around the track of the screws. And there is metal work inside that should be removed carefully for the arthroplasty. Defining the entry point to the medullary canal is very important. And as I said, the callus and the displacement of the greater trochanter, the absence of atomic landmark of the piriformis might deceive you in finding where is the canal. And therefore, it is very important to be very cautious while defining where the entry points to the head joint, to the medullary canal. The disturbed anatomy may also happen with heterotrophic ossification that is filling and obliterating the tissues around the hip. And it may lead to extra-articular engagement as well, having performed an arthroplasty. And therefore, it is very important to remove these bars of heterotrophic ossification that is obstructing your way to get into the medullary canal, and also to give the patient a functional range of movement and to avoid the extra-articular engagement having performed an arthroplasty. Now, the bone quality should be carefully assessed, and if there is bone defect around the proximal femur to be measured and calculated, you have to remember that there are screw holes that act as stress risers. So you shouldn't end the tip of your stem at the level of the screw holes, because this would put the patient into a high of developing post-operative periprosthetic. Both cementless and cemented implants can be used depending on the bone quality, the width of the medullary canal, and the comfort of the patient, of the surgeon as well. Both can be used and employed in these cases, but in many occasions you need to use revision implants instead of primary stems. What is the outcome of total hip arthroplasty to salvage trochanteric fracture? Well, this is a paper that looked at hip arthroplasty published in 2013, and it was looking at the incidence of complication. The incidence of complication in these patients reaches to around 20%. And hematoma formation, following failed internal fixation. Cemented and cementless stem. But two intraoperative fractures happened at level of the of one of the screw holes intraoperatively while reaming for the cementless. I'm going to give you one of the case scenarios just to show you the difficulties and precautions that should be taken. This is a 72-year-old lady who had an unstable trochantric fracture treated by a gamma nail, as you can see. Okay, she's osteoporotic, high comminuted fracture, and I don't think the fixation was optimum from the beginning, but she ended up with very early loosening of the implants and erosion of the bone into the femoral neck and head, and the protrusion of the metal part leg screw has telescoped out all the way. So it is failed the fixation. And again, the protocol should to look at excluding action at the beginning before proceeding to the single stage, and consider the following. If this cures yourself, the question, is this hip infected or not? What is the magnitude of the bone defect of the proximal femur? Have abductor mechanism like greater trochanter as well as upstream attachment. How are you going to achieve this? It's cemented or cementless components. What articulation would be suitable, and the extent of debridement during surgery. Now, intraoperatively, this is identifying where is the remnants of the greater tuberosity and the hip abductor. And this is the vasta lateralis and the soft sleeve that is connecting between the greater trochanter and the vasta lateralis. I think you should maintain the integrity of this soft tissue sleeve all the way while performing hip arthroplasty. You remove the metalwork, and when you remove metalwork, I tend to go standard posterior. If I can reflect the greater trochanter without touching the short external rotators, I do so. If I have to detach the short external rotators from the greater trochanter and reflect it anteriorly, I'll do this, but maintain the tissue sleeve between the greater trochanter and the vasta lateralis. This is a dual mobility cup. And before I insert my stem, I pass wires both from anterior to posterior parallel to the medial cortex of the proximal femur, and a double wire that is going through the lateral cortex. But remember to insert the wires before inserting the stem of the implant. You can see now the stem has been inserted, and the wires are already drilled through the cortices of the proximal femur before insertion of the stem. My preference for the cemented stem in this case is due to the fact that I can adjust the height of the cement stem to keep the tissue tension as I like it to be. And I'm not in need to use a modular cementless stem to achieve this, particularly that the bone of a low quality usually, and many of the patients are very osteoporotic. This is the end of the procedure, and I would like just to highlight what I said at the beginning, that I try to maintain the soft tissue sleeve between the vertebrae and attach it into the greater trochanter and the vastus lateralis. And when I have done so, I've connected the greater trochanter back into the shaft of the femur with the wires, and to close the soft tissue envelope to avoid the presence of some dead space around the implant. This is the post-operative X-ray, and you see along cement, I have already put my stem long enough to avoid stressors that may arise as a result of the screw holes, and played with the wires to reattach the greater trochanter and bring the greater side of the shaft of femur. The greater cannot heal to stem, and if it heals, it needs to heal to bone. So the return of the greater trochanter back to the shaft of the femur is an important step to achieve healing or union of this trochanter in the future. The greater trochanter is encircled by two wires. I'm going to show you the technique in another case. This is another case that is failed VHS backing out the screws from the shaft of femur. And this case scenario, I'm just showing it to show you what would be the outcome of a cemented dual mobility cup at 3 years. I use a cemented stem in this case, but you see, when I use that stem to adjust the height, I use the stem that has locking bolts towards the bottom of it. So I don't need to only rely on the contact between the cemented stem and the shaft, and I can adjust the height of it and use the bolt to maintain this height. Now, the greater trochanter healed with fibrous tissue and skipped from the wires I used for the fixation, but again, it remained, I think, with a fibrous union rather than bony union. The patient was very elderly, and she was satisfied. She asked for X-ray just to be assured that she's doing well. And as you can see, a cemented dual mobility cup that was inserted 3 years ago. Now with the new X-ray, the cement stem is still the same. There is no reducent lines around the cemented cup, and the cementless stem is still stable. Yes, there are some bone resorption from the proximal cup, but I think this is enough for her to mobilize with. About the infected non-union. Well, if you get an infected case, you have to employ the staged protocol for arthroplasty. And this application that I ago for employing a staged protocol to solve infected non-union. Point to look at in this paper was that in the debridement, you should include not only the metalwork, all infected tissues, bony and soft tissues, specimens should be collected and sent for culture sensitivity, and success relies on identifying the organism and the suitable antibiotic in these cases. You use an antibiotic-loaded semen spacer, and the second stage timing would be based on both clinical and regulatory endings. This is a lady who had an infected implant, infected DHS. She suffers from both non-union and protrusion now as a result of the protrusion of the DHS into the side of the ilium. And this is the spacer having removed the head, the metalwork, and debrided everything around this infected implant. And the reconstruction would take care in reconstructing the defect that was created on the side of the acetabulum, pseudolateral part or the roof of the acetabulum, in addition to employing straight fiber stem that is filling the proximal part of the pulmonary canal and bypassing the screw holes to avoid again stress risers. Remember that your stem should be a minimum of 2 cortical widths below the last one of the screw holes to avoid stress risers and periprosthetic fractures. What is the outcome of staged arthroplasty? In my study, 12% of the patients didn't appear for the second stage. They were quite satisfied to have a spacer and walk with. Having had an infected painful head for some time, they were quite satisfied with the spacer and never appeared at the second stage performance. I had a 5% re-infection, and this was in patients whom we couldn't identify the organism during the debridement. Dislocation happened in this series in patients who received 28 millimeter diameter heads, and none of these dislocations happened with the dual mobility articulation. How about total hip in acute trochanteric fracture? Well, if there is pre-existing arthritis, you can consider total hip in acute situation. There is severe osteoporosis and highly comminuted fracture that is not amenable for fixation. You can perform acute total hip, and in patients with polyarticular arthritis like rheumatoid or an autoimmune disorder, you can consider performing the acute hip arthroplasty. Total hip was compared to nails in acute trochanteric fracture in a series of patients over 75 years of age. And this study showed that the mechanical complications with the nail was higher than with the total hip arthroplasty. Remember that in this series, they used dual mobility, cementless mobility cup articulation, and he said that dual mobility with cemented stem achieves a better function than the cementless stem. Perhaps this is because this is a very elderly group of population, and as I said, they have chosen the dual mobility to be used in this series of patients for the fear of developing or for the complication of dislocation, because it's high dislocation when you perform acute total hip for trochanteric fracture. When performing total in acute fracture, you remember when I told you that you maintain the soft tissue sleeve of the greater trochanter vastus medialis as well as the vastus lateralis, the gluteus medius and the vastus lateralis. So you keep it in continuity as it is, and you define where is the medullary canal, and you ream for the medullary canal, and start preparing for the stem. Okay, and before considering to insert a stem, you have to insert the wires for the attachment of the greater trochanter. I use the brushes now, and when I decide the height of the stem, okay, I insert the wire from drying height of the stem, see how is the soft tissue like when you have done so, and see if you can reduce the greater trochanter back to the shaft of the femur. And finally, look at the leg length. You have already healed and prepared your femur. Insert the wire, and it is the wire on the lateral cortex, and a single wire that is running anterior to posterior parallel to the medial cortex of. When you have done so, you insert your stem. This is cemented stem, as I said earlier, and you employ the wires to pass underneath the greater trochanter and around the greater trochanter to bring it back towards the shaft of the femur, as you can see in this case. So you see that having passed the wires, I make sure that I can reduce the greater trochanter back into position to the lateral shaft of the feet. When this is done, you tighten and see the end result as seen on the left-hand side of the screen with the wire under tension now, and the stem is employed and the cemented dual mobility to avoid dislocation. Now, this is to be employed in all trochanter with highly osteoblastic and comminuted fracture. As you see, the greater trochanter is a very important, and the step of reattaching the greater trochanter and adjusting the soft tissue tension is what should be looked at in these cases of acute total for trochanteric fracture. Again, patients with autoimmune disorder, steroid, very osteoporotic, and arthritic hair seen in the CT scan. This is the indication for performing the acute total hip. And as I said, the cemented stem and the cemented dual mobility articulation allow these patients to start mobilization very early on postoperatively with partial or forward bearing from the big healing of the greater trochanter to the side of the shaft of the femur. So finally, if I want to say something, I would say that total hip is commonly performed as a salvage procedure for failed fixation. The overall survival and success is satisfactory. However, there is a high rate of complication, and you have to pay attention to the minor details. The bone quality, the height of your stem, and use dual mobility articulation and long stem. You have to exclude infection in all cases of salvage procedure, because you cannot guarantee that there is infection around implants. And at the end, I would like to thank you very much for your attention. And if there are any questions, I'm quite prepared to answer them.
Thank you so much, Professor Ayman Ebied, for this interesting talk. شكرا جزيلا أستاذنا الفاضل. استمتعنا بالتوك بتاع حضرتك دكتور أيمن بيه.
الله يخليك، أنا متشكر يا دكتور محمد، أنت من ذوقك والله.
لا العفو يا فندم، العفو يا فندم. هو احنا معانا بعض الأسئلة لحضرتك لو وقت حضرتك يسمح يا فندم.
Please, yes, please.
في question from دكتور أحمد أبو سالم. طبعا أخونا وصديقنا العزيز، هو ask you sir, how can you achieve a good cementation of the stem in the presence of screw holes in the femoral shaft?
الحقيقة ده سؤال مهم وكويس خالص، بس افتكر ان انت لما بتشيل السكرو هولز ديت، او لما بتشيل السكروز، يعني الهولز ديت انت يوجوالي انت تقدر توصل لها انك انت تعمل لها سيلينج، سواء كان ان انت تعمل لها سيلينج بانك انت تحط حتت من الاسمنت اللي اتبقى عندك من الاستابلم يعني وانت بتعمل الاستابلم، او حتى في احيان كتيره لو انا بستعمل فينجر بريشر يعني عشان خاطر maintain البريشر اوف ذا بون سيمنت within the medullary canal. انما جنرال سبيكينج ما هيش بيج ايشو، صحيح ما هواش الايديال سيمنتنج تكنيك اللي احنا نحب ان احنا نعمله في الحالات البرايمري هيب، انما ما بيبقاش ماسيف قوي للديجري اللي تمنع ان انت تعمل جود سيمنتيشن.
حضرتك ما تحبش تحط فيها جرافت لو هي الهولز دي كبيره شويه دكتور ايمن بيه؟
لو عندي الفرصه، ان انا لو عندي الفرصه ان انا عندي من الهيد كانسيلر بون يسمح بان انا احط الجرافت ده، انا ممكن اعمل كده. انما في الماجوريتي اوف كيسز ممكن بستعمل حتت اسمنت بسيطه خالص اعمل بيها سيلينج للهولز الكبيره دي من الاستابلم قبل ما اعمل سيمنتيشن للفيمر.
بالظبط. Another question, sir, from Dr. Nadim Ismail. How to determine the level of wires used for attachment of the greater trochanteric?
الوايرز دايما بتبقى حوالي سنتي ونص من اللاترال واير. احنا عندنا تو وايرز، الدبل واير اللي هو بيباس ثرو ذا لاترال كورتكس دوت بيبقى على بعد من الفراكشر سايت على بعد تقريبا سنتي ونص من الاند اوف ذا بون يعني. انما في الميديال سايد برضو انت بتنزل تحت على حوالي مثلا سنتي ونص ولا حاجه، وبيبقى انترو بوستيريور واير ماشي بره الميديال كورتكس بتاعت الفيمر، لان هم دولت اللي بيلفوا حوالين الجريتر تروكانتر عشان تنسركلت. فبيبقى عندك بتبقى انت حابب ان انت زي ما انا بحاول ان انا اوضح كده، يعني انت لو جريتر تروكانتر كده فانت رايح لها بتو وايرز من فوقها عشان تشدها ديستال ترجعها على الشافت بتاع الفيمر، والاثنين التانيين انسركلينج ذا جريتر تروكانتر، واحد فروم انتيريور وواحد بوستيريور، وبيتربطوا او يعني من لهم تايتنس على الاوتر سيرفيس بتاع الجريتر تروكانتر.
Yes, another question, sir, from Dr. Ahmad Taha. Is there any rule of calcary placement arthroplasty in acute fractures?
الحقيقه ان انا بيرسونالي ما عنديش اكسبيرينس بالكالكر ريبليسمنت، يمكن ركبت واحد ولا اثنين في حياتي كلها، فانا ما عنديش جود اكسبيرينس بالكالكر ريبليسمنت بروتيسز، وده يمكن متعلق اكتر بان اللي افيلبل امبلانتس الكالكر ريبليسنج في مصر ما هيش في جود كواليتي يعني، فالواحد ما بيستعملوش. انما اكيد في ناس ثانيه ممكن يكون عندها اكسبيرينس اعلى في الكالكر ريبليسمنت بروتيز.
حضرتك ما بتفضلش الكالكر ريبليسمنت دكتور ايمن بيه في الكومينيتد تروكانتريك؟
ما عنديش اكسبيرينس دي والله يا دكتور محمد، مش عارف ده يمكن مشكلتي انا عشان انا ما اشتغلتش بيه قبل كده الا حلقه ولا اثنين زي ما بقول لك كده. انما الكواليتي بتاعت الكالكر ريبليسمنت بروتيز ان جنرال في مصر ما هيش فيري هاي كواليتي يعني تخلي الواحد يبقى انكارجد ان هو يستعملها.
تمام فندم. Question from Dr. Mahmoud Abdu. What about reattachment of the abductor directly in the stem in the absence of the trochanteric?
مش متاكد ان احنا مش بعتقد ان انت بتعمل بقى كده رابنج للستيم بسوفت تيشو بس، انما ما تقدرش تتكلم عن ان لو انت علقتها على الستيك اللي انا على الحلقه ان انا فاكر ان الستيم ده الجريتر كانتر ما نزلتش الشافت اوف ذا فيمر، ما حصلش، ده حصل فايبرس كده هيلينج اراوند ات يعني keeping it in position، انما this is not healing of the greater trochanter.
Yes, sir. Another question, sir, is there liability of metallosis between the cerclage and the stem as you have direct contact between them?
هو البوسيبيليتي موجوده، وان كان خلي بالك انا بحط الوايرز انما انا بحط سيمنت وبعدين احط فبيبقى في cement mantle between the wires and the stem. انما طبعا البوسيبيليتي موجوده.
Yes, sir. Another question, sir, is there any rule for ethibond suture for trochantric reinsertion?
لا، الايثيبوند انا بستعمله عشان اعمل ريبير للشورت اكسترنال روتيتورز في الجريتر تروكانتر، انما مش عشان اعمل فيكسيشن دي للجريتر تروكانتر نفسها للشفت. لا، الوايرز طبعا اقوى بكتير.
تمام. Another question, how can you adjust the femoral height in very comminuted trochanteric fracture, sir?
ما عندكش اناتوميك لاند ماركس، وزي ما انا وضحت لحضرتك اعمل ترايل بالبروتشز. لو انت عندك سيستم يسمح لك ان البروتشز دي تبقى ستيبل تحت الشافت يعني، وتقدر تعمل عليها ترايل. واذا ما تمكنتش من دوت اعمل ترايل بالاكشوال ستيم نفسه. ممكن ترابط بجوز مثلا عشان تمنتين سم ديجري اوف كونتاكت ما بين الستيم وما بين الميدالري كانال او الشافت اوف ذا فيمر، يخليك تقدر تعمل ترايل عليها وتشوف هترجع الجريتر تروكانتر ازاي، وتشوف السوفت تيشو تنشن والستابيليتي هتبقى شكلها عامل ازاي. في الاخر لو انت طولت رجل العيان يعني سنتي ولا حاجه، ما هيش بيج ايشو كبير في سبيل تاند اب بستيبل جوينت. انما افتكر ان لو انت عندك عيان عامل سباينال فيوجن، ودي حاجه مهمه قوي ان الناس تاخد بالها منها. يمكن انا كان عندي حاله قريب كده، عشان كده انا فاكرها يعني ان انا اتكلم عنها. عيان عامل سباينال فيوجن قبل كده، وانت بتعمل له توتال هيب ارثروبلاستي، سواء كان في تروكانتريك فراكشر او في فراكشر نيك اوف فيمر، الحقيقه انت لازم تبقى واخد بالك قوي ان انت ما تطولش الرجل، لان العيان اللي عامل سباينال فيوجن دوت طولت له مش موجود خالص. انما لو عيان عنده موبايل سباين او يعني ما عندوش فيوز سباين، لو طولت رجليه في حدود سنتي اعتقد ده مقبول. مش عارف طارق تحب تكومنت على ده؟
يعني طبعا اي اجري طبعا على النقطه دي، لان هو اللي عنده دايما الرجل لما بتبقى طويله عشان العيان يمشي بيتلت البلفس شويه. طبعا الايديال سيتويشن ان احنا نديله ايكوال ليج لينث، لكن لو حصل في ليج لينث ديسكريبنسي ويوجوالي بتبقى ان الرجل اللي هي ريبليسد طويله شويه، يا اما بنلبسه في الناحيه الثانيه هيل بحيث ان هو higher than the other side، يا اما هو حتى لو كان الديفرنس بسيط زي في حدود مثلا سنتي 8 مللي حاجه زي كده، في الغالب هو بيأدابت باي tilting the pelvis. لكن لو هو عنده عامل spinal fusion ما بيعرفش يتلت البلفس كويس، فبتبص تلاقي دايما بتبقى الموضوع ده عامل له مشكله. تبص تلاقيه ماشي وتاني ركبته في الرجل الطويله، تلاقي دايما عنده tendency to do a knee flexion to shorten the limb، وده دايما بقى يشتكي، في حين ان هو اللي عنده موبايل سباين ما بيشتكيش، وعنده سنتي ديفرنس وما بيشتكيش وماشي بيها يعني. طبعا I do agree طبعا باللي انت قلته.
The last question, Professor Ayman, how can you detect the entry point in disturbed anatomy and sclerosis of the proximal femur?
اتاكد ان انت تكلير الكيلس والسوفت تيشو، وخد وقتك تعمل بلانت ريمر تي ريمر يعني عشان تفايند دي دالري كانال. ما تستعجلش تستعمل بوتشز، تتاكد ان انت جوه المدلري كانال الاول تبقى اوبريتريتد بفايبر تيشو وكيلس كتير، تتاكد ان انت ويزن المدلري كانال الاول قبل ما تعمل بروتشنج خالص.
هو انا اخر كومنت ليا انا شخصيا بقى دكتور ايمن بيه، انا عجبني قوي في البيبر بتاع سيادتك ان 12% of patients كانوا satisfied بالسبيسر و refusing to do revision
صحيح.
وده يقودنا للسؤال لسيادتك، ايه الانديكيشنز اوف اكسجنال ارثروبلاستي اللي حضرتك شايفها في حاجه زي كده؟
متاكد ان هم زيهم زي الاكسجنال ارثروبلاستي، دولت زيهم زي اللي ماكلين كيوي هيب او سبيسر وهم مبسوطين بيه. هو العيان خلاص ما عندوش ساينس تراكت وبقى مور اور ليس الموبيليتي بتاعته احسن وما عندوش بين، ممكن يكتفي بان هو مركب السبيسر ومبسوط بيه، خاصه لو السبيسر ارتكيوليتنج سبيسر اللي هو زي الكيو هيب اللي احنا بنركبه از سبيسر ده. في عيانين كده، ودولت على فكره احنا بنشوفهم مش بس في ده، مش في الكاتيجوري ده اوف بيشنت، ده كمان في التو ستيج ريفيجن. ممكن الواحد يركب سبيسر لواحد يقول لك خلاص انا مبسوط كده مش عايز اركب البروتيسيس تاني يعني. ده مختلف عن الاكسجن ارثروبلاستي، لان الاكسجن ارثروبلاستي مشكلته طبعا الليمب بيبقى فلير. صحيح في ناس بتاكسبت دوت، بس ما اعتقدش في الالدرلي جروب بوبوليشن حد يقدر يمشي باكسجن ارثروبلاستي كويس.
انا عندي حاله اوريدي فعلا accepting السبيس على حضرتك وساتسفايد بيه جدا وريفيوزنج تو دو second stage revision. We have finished questions بروفيسور ايمن. احنا تعبنا حضرتك والدكتور طارق بيه في الكويستشنز بصراحه، بس التوكس فيري احنا متشكرين جدا لحضراتكم على قبول دعوتنا، وبصراحه ده السيشن ده ميت ذا اكسبرتس، يعني احنا النهارده استمتعنا بالتوكس الجميله دي يا فندم، فنشكر حضرتك.
الله يخليك يا دكتور،
واتشرفنا بحضراتكم النهارده استاذ دكتور طارق الخضراوي، استاذ دكتور ايمن بيه ابيد، يعني شرفنا بحضراتكم النهارده يا فندم.
الشرف لينا وكنا سعداء ان احنا موجودين معاكم النهارده.
الله يخلي حضرتك، ونامل ان تسمحوا لنا ان احنا نشوف حضراتكم دايما معانا ان شاء الله يا فندم.